So, dear students, so we have discussed about new product development, the process of product development, starting from idea generation to testing, execution, product launch, and so on. So, as you go through the course, different modules and the theory part of the course, in this module, we'll have a conversation with practitioners to get a feel of what actually goes on behind the process and how the product development works and so on. So, to give a practitioner's perspective, we have today with us Samir Savarkar. So, he is the founder and CEO of Neurosynaptic Communications Private Limited. So, we'll have a conversation with Samir and see how about his journey in terms of getting the products or having an idea. So we'll understand this. So welcome, Samir sir.
Thank you, Professor Deepti Prakash, for having me here and sharing my views with the students.
Yeah, it's okay. Good. So as we start, so just tell us what is Neurosynaptic.
Sure. So Neurosynaptic is a venture which works on digital healthcare and especially taking the health access to the last mile, which is the rural areas where 70% or 69% of our population actually lives.
Okay.
We develop solutions. First part that we do is we develop technological solutions, which involves medical devices, software solutions, and the workflows that are required for this kind of a delivery. And we also take these services to the last mile by implementing the projects which provide healthcare access to the rural areas. We do this either as services for someone,
okay,
or we do our own clinics. So these are the two ways in which
we'll break it down further. So let's say, what is your just to how did you come up with the idea, or what's your background before this?
Sure. So I come from the Indian Institute of Science, and so does my partner, who is my partner in this venture, Rajiv Kumar. Both of us are from the Indian Institute of Science, and we are hardcore engineers, communication engineers, electrical communication engineers. So before starting this venture, we had an interesting journey. In fact, both of us were together at Indian Institute of Science. Then we were together at Motorola after that in the same team, where we won a lot of awards, etc. Every year of our being at Motorola. And then Rajiv went about a year and a half in the US. He spent there, and I spent about 3 years running another company which is called DAX Software, and that was just sort of a beginning of my entrepreneurial journey, if you may say that, because that position was specifically taken up to understand what entrepreneurship means, which has been my dream always.
Okay.
So when we started, this was more of a...
So you are more of a technology person.
Absolutely,
right?
absolutely.
Yeah? So then how did you think of healthcare? What's the correlation there?
Yes, so we started as a neurotechnology company because that's why the name Neurosynaptic.
Okay.
It actually was from the idea that the neurotechnology is actually a combination of three things: material sciences, nervous system, and electronics.
Okay.
And it dwells into the areas of like prosthetic limbs, robotics, artificial silicon retina, or even implants in the brain, etc. And so initial idea was this, but then we started working with the National Center for Biological
electronics
Sciences.
Engineering and doing masters in ISC, right?
We did no. So after that, I'm talking about in 2000.
Okay.
This is when I had already completed about 5 years of my work at Motorola.
So how did this idea come? Like why in the neural network?
So I read an interesting article about how brain waves were used to determine the alertness level of a driver driving a car.
Okay.
Right. At the same time, I also learned about something called plasticity, neural plasticity, which was more of how one sensory organ's area in the brain gets replaced by another sensory organ's area if that particular organ stops functioning. So for example, I can use if I'm blind, then that area of my brain can be used by other senses, and it
Okay.
adapts to it.
Okay.
So you usually hear that, right?
Huh.
People who have lost their vision, their other
Or some,
senses are
other
very
senses.
sharp, right? So that is because of something called neural plasticity.
Okay.
So this I found very fascinating. And then we also looked at some companies called Alertness Inc., etc., who were working on these so-called uh, uh, gadgets which will be fixed on the head while driving the car, and they would assess the state of the brain waves to be able to determine whether a driver is alert or not. And this was the starting point of getting that interest. Then we saw various other application areas, and
So
so it
you
got
read
us
it
interested.
somewhere, or how
Yes,
did it?
yes,
Or
yes.
part of your courses, or how?
No, it was just a
Curiosity.
chance occurrence. Yeah.
Okay.
I am always curious about technology, being a technologist. So
Okay.
I read this, and it was an immediate click saying this
Okay.
is something that we must work. This is future,
Okay.
right? And so Neurosynaptic was formed.
Okay.
And Rajiv came in. He was working with
Okay.
Zilog, and as a part of that, he had come to India as well. And we seemed to find this very exciting. And then we approached Professor Vijay Raghavan, who was the director of National Center for Biological Sciences, NCBS, at that point
Okay.
of time. And he seemed to be excited with this idea too. So he put us in touch with some professors, and we did our initial projects there
Okay.
after forming the company. And these were like, how can we bring vision to blind
Okay.
by using neural plasticity? So we
Okay.
used tongue
Okay.
and a denture sort of a thing, where we put electrode array and projected the camera's feed into that electrode array and sensed it with the tongue's sensory organs, neurons.
Okay.
Basically, blind people would be able to navigate the obstacles
By saying
by
something.
by that projection, by sensing the electrical pulses. So you had a 16 by 16 electrode array, which would tell you about the obstacles on that sort of a plate. So like I touch, right,
Okay.
braille. So similarly it is. So now tongue has a largest neuron density, right, because of which we.
So the device is put in the.
Like a denture.
Okay.
Yes.
Okay.
So like a denture, you fix it, and then you start navigating with the help of tongue. So you can see with your tongue, if I may say that, right?
Okay.
So the brain adapts the taste sense part of the
So
brain.
where is the signal? So how does the device getting the signal?
So device is getting signal from a camera.
Okay.
The camera is looking in front.
Okay.
Right. The person can't look. The camera is looking, and then it. So this is very old. This is 15 years old.
Technology.
16 years old technology. But
Okay.
we did that successfully, and we did experiment it with the National Center for Blind. There was a National Association of Blind, and we tested it out, and it worked beautifully well. But then at the around the
So
same
then
time.
who was your customer at that point? Are you like targeting the blind people, or how was it?
Yeah. So this was sort of a solution for all the blind people to see with maybe a spec. And now you have a lot of such solutions coming in, which has camera in the glasses, Google Glass, and so on. But at that point of time, it was not. So this was a very novel concept, and we thought we might be able to get that whole thing into a product which will be able to help all the blind people navigate. But then during that period, there was a chance meeting with Professor Ashok Jhunjhunwala, who was the director of Tenet Group and professor at IIT Chennai at that time. And
so students, if you don't know, so Professor Ashok Jhunjhunwala is a pioneer and legend in many digital applications and so on. Today we see the UPI applications and so on. So he is kind of, you can Google about Dr. Ashok Jhunjhunwala. He was founder of the labs and many innovative initiatives at IIT Madras. Yeah.
In fact, there was a whole ecosystem at IIT Madras.
Yes.
And I'm going to explain about that.
Yeah.
So at least that part which I know, right? Because I am not exposed to the whole thing. But
yeah.
So when we actually attended that presentation from, we means I and Rajiv, attended that presentation from Professor Jhunjhunwala at IISc and understood that, there is such a huge issue, and we always knew that there is an issue of healthcare at the last mile, because both Rajiv and I come from the rural background in some way or the other. So it was there at the background always. We knew that there is this problem. But it suddenly came to the forefront when professor presented what they were doing at IIT Madras. And what they were doing was really aggregating various services, converting it into a model, taking into the rural areas, which was sort of a kiosk. At that point of time, it was unheard of. A kiosk in the rural areas operated by the local local worker, right, operator.
So who was
who was
doing
an
it?
entrepreneur.
Okay, these are the part of the ecosystem.
Yes, yes, yes. So there was a technology which was beautiful technology, and there was a company called Midas Communications. Midas Communications built this whole DECT based technology. So there was GSM, there was CDM, and there was DECT. DECT sort of gives the best ARPU, return per user kind of a thing.
That's
right?
we use in the telecom.
Yes, so that was a technology which sort of became the backbone of various other ventures also, like Nlog Communications. Nlog Communications was another outfit that came out of IIT Madras at that point of time, and it was promoting these rural kiosks. Rural kiosks which were run by the entrepreneurs, connectivity provided by the DECT, which was Core DECT, which was called as Core DECT at that point of time. Supplied by Midas. With a central tower and 30-kilometer radius, it would provide a wireless connectivity with a 32 kilobits per second or 64 kilobits per second channel, both uplink and downlink. And that became sort of a channel for various services. So there was educational services which were started at IIT Madras at that time for 10th standard, 12th standard, school children, English speaking courses, mathematics, various others.
So the
start of
network
tele-education.
infrastructure kind of built at the rural level, which helped to facilitate other functions like your health or education and so on.
Health, education, e-governance.
E-governance,
right? At that time, CSCs were not there. So this whole setup is a, I would say, pioneer, and not only pioneer but actually harbinger of so many technologies that later came up. One of them that you see is the common service centers or community service centers today. So it was the outcome of these kiosks, which was being done by Nlog in the South India and Drishti in the North India, etc. All of those experiments that resulted finally in the CSC scheme, and then it's expanded throughout the nation, and then we today have so many community service centers providing e-governance services, right?
So you are based in IIT Madras at that point, getting
some
incubated, or
I think
just
about a year Rajiv and I spent at IIT Madras learning various things, because all said and done, even though we both were from the EC department, the understanding of hardware product at that point of time did not exist much in India, except I think few pockets, and IIT Madras was one of those pockets. So actually IIT Madras taught us to develop a digital product, a hardware product, which even today there are not many hardware products in India, right? So I think that is where the learning was for me in terms of building the hardware products. But I'll get to that. Before that, so one is the community service center that came out of this whole thing. Second was this connectivity technology. Third part of it was e-education. So IIT Chennai has been pioneer in e-education, but that is where it started. So now we have all these full-fledged courses, and IIT Madras is leading
the digital
and it has spread everywhere, right? Tele-education, digital education, online education. So that all started there. And then this whole concept of rural upliftment and driving it through business. Driving it through business, because then profit becomes the main driver. And the whole concept behind this thing was that people who run the system must earn from it, must profit from it. Only then the system continues to exist and continues to expand, right? So it becomes a gainful employment for people who are running it. That was the concept.
This is an interesting concept that you are talking about, right? See, when we see organizations are two types. One is the for-profit organizations, where the focus is on maximizing shareholder value.
Right.
There is one set of organizations, what we call the NGOs or social sector and so on, which are supposed to solve social problems and not be for profit, right? So how do you find a bridge between the two?
Yeah, so I believe that, I believe two philosophies. One that was tenet groups and professors, which I heard, which was more like a system must be profit making to be able to scale on its own and scale to a large extent, right? Must be generating profit for people who are running it. At the same time, Professor Vijay Raghavan had another set of philosophies, which is profit making but not profiteering, right?
Okay. Can you
So,
elaborate? What's the basic difference?
so basically, you don't really try to make, try to, how do you say, loot in a
Okay.
business.
Okay.
You try to make genuine profits,
Okay.
profits which are healthy for your growth, but not really at the expense of somebody,
Okay.
but trying to add the value and to make life better for people. So both simultaneously coexist. So profit making, not for profiteering, and system must make profit. So this is what Neurosynaptic stands on today. This is the philosophy.
I'll okay, again I'll say, so again to elaborate what you are saying is that, see, the maximizing shareholder value typically gives lot of importance on the investors or the in terms of your shareholders, right? The shareholders must make gain, or let's say the investor must gain in terms of valuation and so on, irrespective of the impact and other aspects. So that approach probably is a, as we can understand, is a narrow construct, that if you look at that point, you will only chase profit, right? So all the social problems that you see, let's say not taking care of your employees or so on, the shareholders interest is in maximizing profit, irrespective. Today we will see the worker issues and so on, which are also part of that. Again, when you say profiteering, you have to also look at the social welfare of your all stakeholders, right? The customers, the suppliers, and so on, right? That's a broad idea of a shareholder-centric view and a stakeholder-centric view.
Absolutely.
Yeah. Okay.
Absolutely. So this was set up as a profit-making entity, and we also got initial support from IIT Madras and a few small investors who had invested in this concept. But then I would say, so what was really thrown at us as a challenge, and this was interesting because we were working on neurotechnology already, but then when this problem was sort of seen by us, it came to the foreground instead of being at the background. We always knew health issue existed, health delivery issues at the last mile.
Who was your, let's say when you started, who was your customer? In your mind, who was the customer? And as you go through this process, so how does it change? Let's say your focus on who is my customer.
Yeah, so I mean, initially it was just that there is a huge problem and we need to solve it, right? And we were sort of out of IISc with 7 years of experience totally, and ready to solve anything. And then at that point of time, it felt like an easy problem to solve. Okay, and that's also how students pursue the problems, right? And I was not strictly a student, but at that point of time, new entrepreneur, right? And it seemed that what is required is just building some technology which will now, if you understand the rural healthcare problem, maybe I'll spend a minute on it.
Yeah, sure.
So what we have is 69-70% of population living in rural areas, and population has been migrating also. So this percentage has been steadily reducing, but it will take a long time and a huge overload in the urban areas to be able to really have a systemic or major shift in this percentage. So a large population, even today, if I may say, 31% of the population has to travel more than 30 kilometers just to access what we call as a nominal healthcare, right? And that is a problem which was even more starker 15-20 years ago, 20-23 years ago when we started on this.
31 kilometers, when you say, it would be probably true for slightly developed states. Even the hinterland or extreme
northeast it is very bad. In the northern part it is a little less bad.
Yeah, so remote
southern
it can
part
be
is
up to
great.
100. I know, like the rural tribal districts in Odisha will have, like, you have to travel 100 kilometers.
Absolutely. And so it is so difficult that people normally tend to not access it, and it becomes gender selective, it becomes age selective. Geriatric population never gets access because it's considered as a part of life, and women never get access because they absorb all those healthcare issues into themselves. Only working males or working population and the children get the priority. So when they are ill, they are taken somewhere, and then somebody has to go with them. So all of those expenses, they are huge expenses. But then, so what people do is they avoid going.
Okay.
And because of that avoidance, it becomes a very critical problem when they finally reach the health system. And when that happens, it is so critical that they end up selling assets, selling livestock, selling everything that they have, all the savings, etc. And they permanently go below the poverty line. There are about 100 million people per year just going below the poverty line because of their healthcare expenditure. And this is the largest non-productive debt on rural India today. And it has been there since like last so many donkey's years, right? So now, how to solve this? Government has tried a lot of methods. So largest provider in the rural health today is government, right? Through its network of close to 1.5 lakh sub-centers and primary healthcare centers and rural hospitals and CHCs and so many district hospitals, there is a huge network. And government is trying to solve this problem. However, there is a lot of disconnect there. And this disconnect we saw very early there, but of course later than our starting point, and I'll come to that. So we thought attempts to take doctors to the rural areas have repeatedly failed.
Correct. Okay.
Right? And that is because of various reasons, and they are all genuine reasons. Unfortunately, because the doctors are not there, there is also no infrastructure, there is also no medical community like nurses, labs, pharmacies, nothing is there, right, in the rural areas. Because all of this is, even though the population is 69%, it is distributed in more than 6 lakh villages.
Correct. Okay.
So it is like per village you have about 1,200 kind of a population. So they are all in pockets. It's very difficult to aggregate and put something together and get it financially viable.
Okay.
Right? So there is.
So what you're saying, for a doctor to come again, so government has been mandating doctors to have mandatory rural stint and so on. But you can't have a scalable model or at least basic infrastructure or social structure for the doctor to actually go there.
Correct. And so it is all genuine reasons. I wouldn't say that it is. And still people are there, doctors are there at PHCs who are sort of addressing these needs to whatever extent possible today. But then we have OPD and IPD statistics. People who are there for small ailments, they do what you call as access PHC healthcare, primary healthcare centers, they access healthcare at. But as soon as you start, and they also access alternate healthcare. So the primary healthcare OPD services, people go at government as well as others. But when it comes to IPD, they have no option. They have to go to inpatient when you have to get admitted.
IPD is the inpatient,
Yes,
OPD is the outpatient. Okay.
So they have no option to go to other than, they have no option other than going to the government and getting admitted there, right? Because the costs elsewhere are huge and they don't also know anything there. So while the government is the largest healthcare provider, there is still huge access gap, right? Can we either augment government or we set up something parallel, which is a private, to be able to serve these access issues, right? So our initial thought, and this was Neurosynaptics' initial idea, was very simple. We were naive. We said, okay, let's develop a product, connect. We already have these kiosks which are being built by IIT Chennai and many others. And then we will basically put healthcare as a service in those kiosks and then connect to the doctor at remote end. And doctor from the urban area can actually see the patients in the rural areas and provide healthcare services. Their need is satisfied, they can pay a little bit of it, which is sufficient for the doctor's fee and the technology in between, and also results in earning of this entrepreneur who is operating this clinic. Right? So all of this becomes a beautiful business model,
so-called business model, kind of aggregator, right? The kiosk is the hardware which the IIT system is providing.
Correct. Is a setup, is a channel, right?
Yeah.
With IIT's Enlock was the name of the
Enlock was-
company.
yeah.
So DECT was providing the connectivity and getting paid for it. The operator was providing services and getting paid for it. Operator was a franchisee of a system and so on. So this was a beautiful initial setup. And the initial business model was very simple. We produced thousands of these. Okay, so one more component I failed to cover. There was a meeting that we called at IIT Chennai, and this was a meeting of all the doctors who were interested in healthcare access at rural areas. This included Dr. Ganapati from Apollo Telemedicine Society. Then it included Dr. Basu John, then various other doctors from Vellore Institute of Technology, Vellore Medical College, and so on. A lot of medical community, some investor community, and a few others, technologists. So there was a huge meeting, and then we actually discussed about the requirements, that we want to solve this problem. How can we solve? You tell us. What do you want us to do?
Okay.
Right? And that was the initial requirements gathering.
At this point, doctors are your customers.
Doctors were advisors. So finally, the customer is that rural patient who pays for the system,
Okay.
and the doctors who use, because they are going to make a gainful
User.
consultation.
So doctor is the user.
User, yes.
Yeah. So in terms of your user feedback and all, the doctors have to provide.
Right.
In
And the
terms of
kiosk guys were the channel. Right. And they would buy only if it is profitable. So we started with this simple business model, that we just need to produce these devices which the doctors told us. Doctor said, we want some basic parameters.
Okay.
Without that we can't operate. Right.
Okay. So
we want temperature, we want blood pressure, we want pulse oximetry, we want to listen to the heart of the patient, and we want maybe as a experimental parameter ECG.
ECG, okay.
Right? So can you put these devices together and work at the rural areas?
Okay.
Now at that point of time, it was very
the kiosk
interesting.
will probably monitor some of those basic parameters and transmit to
so the
doctors.
operator becomes the doctor's supporter. So somebody like a compounder, somebody like an operator who helps the doctor and the patient to communicate with each other.
Okay.
Right. Then there is this hardware piece which the doctor gets help from to understand the basic physiological parameters of the patient. And then there is a video audio conferencing and electronic medical record, and maybe some sort of a workflow, OPD workflow, where the patient gets registered and so on. So this was the initial idea
So
of the
this
product.
operator is a local person who is trained?
Yes. He is or she is an entrepreneur, right, who has invested into this kiosk system to be able to make returns on it. Right. So by providing aggregation of services. So there are tele-education services, there are tele-health services, there are e-governance services like e-Darbar and all. There were those services where collector used to reach out to the villagers with the help of this same system. And the whole idea was also to demonstrate at that point of time, and this is the Tenet initiative, of course. I am not saying this is not ours, but the concept is that can we take this whole thing to the government and ask them to set up everywhere in the country, which eventually succeeded. Of course, now we see community service centers, so which originated from these efforts, initial efforts. But okay, coming back to health.
Yeah, so one point also I would like to highlight, that you are not trying to invent everything, right?
Correct.
You are trying to leverage the ecosystem that is being developed. So the hardware and the tenants and all these people who are developing something,
Absolutely.
and then plugging into there to solve a larger problem.
Absolutely. And the problem is so large that, even if we are able to make a 10% dent in the system, it's a huge revenue, it's a huge need met, and it's a huge business. Right. So that was the whole concept behind this. And but then we did not know hardware development at that time. There are very few companies in India in 2002 which were manufacturing hardware, that too indigenous. Why indigenous is required here? So very, very interesting. So today you see a different scenario, but at that point of time, electricity was a major issue in the villages. Connectivity was a major issue in the villages, and medical infrastructure also. So when I talk about connectivity, electricity, there was a limited number of hours of electricity in the villages. And as soon as the electricity is available, the farming pumps would switch on. And so there was a huge what you say upsurge, downsurge in the surges in the electrical supply, and that would destroy any medical equipment, because medical equipment were not built to handle this kind of power supply,
Okay.
right?
So interesting. I'll just so this, like, our urban kids may not understand the nuances. Like, see, this is, at those days, most of the rural places didn't have full regular power supply. You would probably get power supply for 3 or 4 hours, sometimes 8 or 10 hours in the day, right? In that time, all other devices and all other farming appliances and everything will get plugged in. So your load increases, and if these are sophisticated medical equipments, the equipments may not be able to handle that kind of low voltage
Yeah.
fluctuation and so on, right?
Because
These
they
are peculiar problems with, again, so when we get into a different market, if you are coming from typical urban background where you don't see so much power cuts, you probably may not appreciate these problems unless you go there, right? Yeah.
True, true. And it's not the only problem. Electricity was one,
Yeah.
but then there was also perception issue. Villagers would perceive getting shocks to a system which is connected to electricity. So we had to build a system which was actually not connected to electricity, but would charge from electricity and then can be used, right? So it was a completely disconnected wireless communication. So a system which was like very different from what was existing.
Okay.
Right? And this was very interesting because later mobile phones
This
arrived,
wireless charging.
right?
Okay.
Once mobile phones arrived, people became much more tech savvy, and then all of these set of fears were gone. So this was a part of market evolution as we progress. But
Okay.
so initially this was also a major concern, that people feared shock when you connect ECG electrodes and all those things. So it was a major put off for some of the villagers and all. They said, no, we are afraid of this. So those kind of initial surveys gave us some inputs. Then connectivity. Now the connectivity that was available at these kiosks where we were operating was 32 kilobits per second. And then it was expandable to 64 kilobits per second, but the charges would increase. There was no other connectivity. There was phones, even BSNL towers, etc. were not there at that point of time. And there was absolutely no connectivity situation on which this kind of a continuous video conferencing would work.
Okay.
So, so we worked on Cordect at that point of time. And later we tried to work on BSNL system and all. It terribly failed in the northern part of India. We did some experiments with an organization called Drishti. Drishti provided.
So you started
kiosks.
with a pilot in some states, or like what is your expansion at that?
Initial all the pilots were done in Tamil Nadu. Because Tamil Nadu relatively at least has a better infrastructure. But that's also a bad thing, because health needs are also less because of that. Because health infrastructure is also better than the other parts of India. So what we saw is a stark difference. In the northern part of India, infrastructure, connectivity, electricity, too much different from the southern part of India, where it was slightly better.
So by the time you went to north, you had already set up and
yeah. So we were still in experimental phase, right? Because and this is very important part of our journey, because 2 years down the line our product was ready. We manufactured it. We put together all of these sensors. We built as per the expectations of the medical community and the people that we had. And then we started a center in southern part on an analog kiosk, right? And there it was an eye opener for us. What happened was one week we got heavy traffic of patients, and next week there was zero traffic. And we were wondering what happened. And then we figured out that this center was providing beautiful consultation services, but there was no medicine, right? Okay. So when the doctor said you take this medicine, the patient anyways had to go to a pharmacy, which was 3 kilometers down the line. Okay. So patient said, okay, why don't I just ask the pharmacist anyway, because that's what I am doing all the while. Right. So, and patient may not understand the big difference between the pharmacist and a doctor in a consultation. So the whole thing is like, unless, and this was a big realization for us from a point of view of ecosystem missing. This was perhaps the first experiment in the rural areas, and in fact Apollo Hospitals was kind enough to do the first clinical validations, etc. for our devices. Dr. Ganpati did that, and people were satisfied with technology. Technology worked beautifully, but the ecosystem was missing. Right? Now there came a very big point of decision for Neurosynaptic as to whether we want to continue or we want to, sort of abandon this and take it up when market is ready.
Okay.
As a business,
So you are
it would be
saying
very
at
prudent.
that point that it is ahead of the time.
Very much ahead of the time. I would at least about 16, 17 years ahead of time.
Okay.
Right? And it was a huge time gap.
Okay.
But then the question was whether we abandon it or we continue solving that problem. And after a lot of thinking, Rajiv and I took a decision that if we don't solve our own problems, then who will, right? And probably there is something called a development sector, right? This is a sector which basically works on trying to change the ground realities, etc. And we switched from a business, pure business that we had in mind to what we call as a development sector in this while. So in 2005, 2006, we came across an organization called World Health Partners, not World Health Partners, Janani. And Janani's team was doing a massive work in certain domain, not necessarily the healthcare domain, but prevention of unwanted pregnancies, etc., which is a highly non-incentivized work, right? So selling of contraceptives and various other things. And they had set up across Bihar about 44,000 centers at the grassroots level, run by the local operators, earning incentives through this highly non-incentive sale with the help of certain cross-subsidization. Okay. So they were actually selling few things of this, few things of that. This earned more profit, but this they could sell only if they sold this and the other one. And so cross subsidy.
At this stage, as you grow to different states, you will be discovering different set of challenges.
Yes.
And ground issues and so on.
Correct. So the idea was, after we realized that ecosystem is missing, the whole way of looking at the problem changed. Okay. Now we were trying to look for models which were trying to solve ecosystem. Rather than just the technology. Okay. Right? And this was a very difficult period because we experimented all over. We experimented in central India with the help of Gramdoot. We experimented in northern India with Drishti and southern India with Analog Communications. We had very little resources at our disposal. Of course, IIT Madras was at help. Professor Junjunwala was there. But we had a very difficult time in trying to figure out what we should be how we should be solving this, until we came across this Janani and we saw this is the way, forward for any large scale system to actually work on the ground. Okay. And it was not just technology. They call even the processes as technology. Okay. Professor Christensen's, definition. Disruption. It's not just the technology, but also the processes become technology because they are sort of solving the ground level problem. So they used processes beautifully. So when we initially negotiated it, of course, it was not their main what I would say agenda to set up telemedicine, but they loved this idea because they realized the power of it, right? And then this whole organization resulted in initiation of another organization called World Health Partners, which was set up in Delhi in 2007.
So now you are also thinking about not only getting the technology, also getting the medicine to the...
yeah, so for medicines, we did various experiments. Okay. So for example, initial...
So you want different partners who will facilitate.
Correct. So we tied up with Piramal Group, for example, at that point of time. And we tied up with ILNFS. We did some projects together to... So whole concept of now kiosks are an aggregation of services, right? Then we realized that the land record services does not go very well with what we call as the healthcare services, because the kind of population that comes to access those services is completely different. Okay. I mean, a woman who is talking about her sensitive problems would not come to a place where there is all this, thing going on.
So these kiosks are having all other e-governance and other problems also.
Correct. Yeah. So we sort of identified what would go well. Education will go well with health, but not the land record or not the e-governance, because the kind of population coming in, kind of sensitivities are different. So then we worked a little bit on how we should structure these kiosks so that these services can run. The other thing was also, and very important learning was that when we started getting into the community for promotion of these clinics and doing the tests. So we added a glucose test also. We realized that there is a very strong chance that the operator herself tries to figure out the doctor's behavior and tries to become a quack herself.
Okay.
Right? This is a very serious problem.
Okay.
We are trying to make quality healthcare access available, and then we are actually introducing quackery. Right? That is not negotiable at all. That we cannot have. So then that generated an improvement in the product, and we solved that problem by what we call as devices which are aware. So there is some term that we coin for it. Basically, every usage of the device, these are like usage aware devices. So the device gets connected to the system for the usage. It does not operate standalone. So even till date, our devices are not standalone devices.
Okay.
They work only when connected. So when they are connected, they basically record the usage, and so someone can monitor that usage, right? So basically what it means is that I am not allowing somebody to just use it unchecked, and that we also filed for
So this
a
since you said the
disclosure for it.
glucose test, so do you like collect blood samples and do the test and or that's not?
So this glucose test is a self test, capillary blood test. So I can prick a fingertip and get the drop of blood and get that test. What we use in homes, right, typically. So it is a point of care device.
Okay.
So it can be used by even myself doing the test. So it is not a very big challenge.
Okay.
But people in the rural areas don't know how to use it. So the operator assists
Okay.
in using this device. And the test results help the doctor to make a qualified diagnosis. Right? So that was the whole idea. But then the nurses started testing it and started prescribing on their own. It became very dangerous. So we stopped it immediately.
Okay.
And we brought out that connected devices or aware devices mechanism. And that became a theory of all of our products beyond that. Even today, the products are connected devices. And ours are the only devices which are connected devices. They are specifically made only for telemedicine. Okay, so these kind of learnings. But then we started even the location of kiosks. We wanted to reach the medicines, right? So how to take the medicine? So we studied a lot on what goes to the village daily.
Okay.
Right, because medicine is required there and then. I got a diagnosis, I got a prescription, now I need medicine. So how can I reach the medicine there? So we found that not even newspaper goes to those villages daily, but Coca-Cola supply chain is there.
Okay.
That goes daily, that replenishes daily. So some very interesting discoveries like this. So we started what we called as bus route. So we tied up with Piramal Group. We started a central pharmacy and put all the kiosks or selected all those kiosks which were on the bus route. So that as soon as the consultation is done, it can be handed over to the bus, it can be delivered to the kiosk operator, and the kiosk operator can locally deliver it there. So it functioned well for some time. But then later other needs came up. How do I get the lab test done, because this is insufficient for me. I can't decide without a blood check whether some guy is having infection or not. Right? So genuine problems. So there was Dr. Sukumar with Shanti Clinic, etc. Chaya Clinic in the same area, Madurai area, where we ran these experiments for 1 or 2 years very well. Did a lot of learnings, but not a business model, because we still could not solve all of these problems. And during this period, we came across Janani and various other initiatives. So then in 2007, finally, Janani was established. World Health Partners was established. Out of the people who were running Janani, some of the team members came out and established this. It's an NGO. We went to the Buffett Foundation together, because this NGO had connections at various donor levels, and this opened up that sector for us. Till then, we were not really looking at the donor sector, right? And we were not aware of the development sector, which was funded by such finances. So the first project we got was from, we actually Neurosynaptic went with World Health Partners, who was an NGO, to Susan Thompson Buffett Foundation and made a pitch together to get that. That's also the year when we received the World Economic Forum's Technology Pioneer Award.
Okay.
And this is a very prestigious award. This is an award which I think till date about 4 or 5 Indian companies have got.
Okay. This is 2007-8?
2008, yeah, 2007 December. That's when we got. In fact, we used that in the pitch to the Buffett Foundation as well.
Okay.
And Buffett Foundation funded initial 128 centers in 3 districts of Muzaffarnagar, Bijnor and Meerut in UP. That was our very first project at a reasonable scale, 128 centers, right? But then connectivity became a spoil sport. So there was no ground level connectivity, or what we call as terrestrial connectivity. And our whole philosophy is that, and that's where we are, we were completely, we had locked horns with some of the other initiatives that were strongly promoted by Apollo and ISRO and various others who were using satellite connectivity for taking healthcare to the last mile. We said satellite connectivity based solutions won't work. And why? It is because, it's a very precious resource. You cannot have infinite satellite connectivity, and so it needs to be terrestrial connectivity. And we were looking for terrestrial connectivity solutions. But then at that point of time, the mobile network was just appearing, right? I'm talking about 2007. So we had these low bandwidth phones, etc. Not even the what do you call the data link in the mobile phone, in the GSM phones. Even that was not there. So what we did was, we did end up signing for satellite connectivities for these centers, and the bandwidth is very expensive. It charges per kilobits. But then advantage was that we also were working on a very low bandwidth. So very low bandwidth video audio conferencing. Now, very interesting part. So when we developed the devices, we also ended up developing other parts which work on those limited resources, right? Which included a video conferencing, which was running on a 32 kilobits per second, uplink and downlink. It was a small video, stamp size video, QSIF, SIF. But then that was enough for the patients to get comfort talking to the doctor. And it was not refreshing at a lot of speed, not 30 frames per second, but maybe 15 frames per second. But we were able to do that. So that was enough for the patients and the doctors. Now, all of these innovations.
So what is the incentive for the doctor here?
Doctor gets paid. So there are 2 incentives. One is a social incentive, one is a financial incentive. There are a lot of doctors who actually want to do something, but are unable to do because of the social pressures. And secondly, if they can do this at the place where they are sitting anyways, and waiting for their patients, plus also getting additional payment for it, right? So, and some people are even willing to do it just out of the charity. So there is a mixed market. Again, you see a combination of a financial and a non-financial.
How did you break that? How did you
So in fact, initial parts were with various clinics and hospitals who were run by NGOs in the rural areas, who were willing to do this, who were looking at it. So as I was mentioning, some hospital, Chaya Nursing Home, Dr. Sukumar, he was very, very much dedicated towards this. He would personally spend his time doing this. And then many other doctors. Similarly, we had Meenakshi Mission Hospital and Research Center at that point of time. Slightly later, maybe 2009 or so, that came in, and that said we wanted to set up centers. Even till today, Meenakshi Mission is running these centers, about 15 or 16 centers all over Tamil Nadu with our technology, which basically are the centers which reach their services in those remote areas which are their catchment areas, but not really reachable to them directly. So vans, etc. are very expensive propositions. Instead, local entrepreneur charging the local patients for that, and then hospital charging if they need to come back to the hospital. That's the model that Meenakshi Mission Hospital uses.
Mostly the challenges were at the patient side, not so much at the doctor side.
Yes, doctor's side biggest challenge was the acceptability of telemedicine as a solution for healthcare provisioning. And I can tell you, this came from very elite doctors to very basic doctors also. And that has remained one of the major hurdles throughout until COVID. right? Acceptability by the providers, and I can understand their concerns. So
Yeah.
basically, you are looking at a patient remotely.
Hmm.
You are not able to do physical examination. You are not able to actually observe the patient, whether the patient is
Breathing,
having any other symptoms and so on. You are solely dependent on a
the-
non-medical person who is operating there and sitting next to patient. So this is a very interesting concern, and we didn't know how to solve it, right? So the only way to solve is having a medically aware nurse there, and that is something that we later resorted to. But so that was so that one concern, and then there was another concern also, like how do I know that this operator is actually doing work correctly, right? For example, typing mistakes, right? And then there were all these local language words which not necessarily known by the doctors, and the operator would enter something and the doctor would have to interpret based on that.
Okay.
Right. So there are various other, and then if there is an emergency, they can't do anything. So there were these very valid concerns of doctors also. But then, so our philosophy always has been like, is it better than the current system?
Okay.
Right. What is the current system? Current system is that you have no access. Right. A slightly better system is you have a little bit of access, right? Maybe you can't take a doctor fully there, but at least you have some access, right? And even the stalwarts today of telemedicine, whoever are very well known and very public, if I take names, you will know them. They were against the idea of having teleconsultation in the rural areas without doctor, meaning without having physically doctor present there. And we said, like the connectivity, using the satellite connectivity defeats the purpose of the model, having a doctor at the rural center also defeats the purpose of the model, because you can't solve it that way. There is no possibility, right? And so we maintained our sort of workflow the way we were. We were also sort of not very liked because of that, because we weren't listening to many of the communities, doctors communities or connectivity communities, which were, but that apart.
So how is your clarity evolving about what you want to do and execute over this?
So whole of the journey from, so after 2008, when we actually set up these clinics, 2007 with Buffett Foundation, we showed it to Bill and Melinda Gates Foundation, and World Health Partners was able to get a much larger grant to run a much larger program, and that became the first and largest telemedicine program in India at that scale. About 1300 centers, 1300 centers in 21 districts of Bihar. Okay. One of the most backward, one of the very backward states in the northern India. And it was not a government program. So it was a completely parallel program. So WHP had a very set of interesting philosophies as an organization, because they have run an NGO now, right? And this is how. So I say there are various pillars of these solutions, like Professor Jhunjhunwala becomes one pillar. Similarly, Mr. Gopi Gopal Krishnan, who was heading WHP, becomes another pillar of what we learned from. So an NGO running a program, how does it run efficiently? Right? Inefficiency is a hallmark of various NGO operations, right? That is because it is perceived that it is not professional. And people have donated money, so the value of that may not be that much. People may not really monitor it, and so on. But WHP had a very interesting philosophy. It used to get private providers to run the program. Okay. Always, not its own employees. Private providers which are cross-incentivized. So there are certain activities which are non-incentivized because of their nature. So like if you let's say sell a contraceptive, you get very little margin on it, right? It is inherently low cost. So it is a very non-incentivized work. But then can you incentivize this provider with something else which generates more profit and tie it up to the targets on the non-incentivized one? So it's a cross subsidy basically, but cross incentivization also. So that philosophy we sort of merged onto this program. So what actually was the program for the World Health Partners was more on leishmaniasis, childhood pneumonia, diarrhea, and tuberculosis.
Okay.
Those were the 4 pillars of the program for which they got a grant. And they implemented it using private providers, and we became their technology partners and set up telemedicine in all these 1300 village outlets with the help of the local RMP with his wife.
Okay.
So basically there is an RMP, there is his wife,
So
and Gaon ki Biwi kind of a thing.
RMP is
Registered medical practitioner.
Okay.
So there is technically registered medical practitioner, somebody who has come through sort of a different stream of registration. But
you are avoiding, let's say when you go to Bihar, you are avoiding the government system.
Not avoiding the government system. Government system did not see this as a solution.
Okay. But you are not approaching them or getting
We did. So I'll tell you that. So initially in the 2005, 6, 7, 8, 9, when we approached government, the telemedicine was a very sort of very bad word, right? And it was spoiled because a lot of experiments were done and they had closed down, right? And government officials said this does not work. And whenever we approached any government officials, they said, no, we have seen it already. There is no, it doesn't work. So please don't waste our time, right? So there was so much of negativity about telemedicine around that time. So government was not a solution. But what we did in this program, right, the Bihar program, was that there was a linkage to the government system for all these 4 diseases. So whenever there was a patient of these, the local RMP was supposed to refer to the government system, and it gets registered there, like TB, like diarrhea. And government had definitely a very big ambitious program around those. But then it was no incentive for this operator, right? We use telemedicine as incentive. So telemedicine, how did that RMP get the telemedicine facility? 1 out of 10 RMPs actually was selected, right, based on the various parameters of WHP to run that telemedicine center in that region. Rest all became the sort of conduits or agents into that telemedicine system. So that guy sort of increased, or his or her prestige increased in the community. So that doctor became important, and that doctor became known for the Sky Health was the brand, Sky Health Clinic, right? Okay. And then there was a complete Sky Meds, which was also started by WHP to bridge the pharmacy, because we took this learning to the entire ecosystem there, and then a whole Sky Meds was built with more than 10,000 pharmacies supply chain by WHP for this program, so that any medicine that is prescribed would be available for the patient when they need it. Then we connected up about 500 or 600 labs, so that the patient does not have to travel multiple times. Right? One of the basic issue is that I need a blood test. Now what do I do? Right? So we connected the labs. Labs would come and pick up the sample, and the results would be published online. I'm talking of 2008, right? So the labs were having a computer and our software license, and they would upload the result of that patient there, which would be obtained at the village level by this RMP when the patient comes for a follow-up visit. And most of the RMPs had their pharmacy due to some license or other pharmacy license used to be there, or if not, then even out of OTC drugs at the Kirana shops, because 10,000 pharmacies, like you may not have that number. Right?
So essentially, you are from the rural patient perspective, so he has to travel 3 times for this thing. Correct. Right? One is for the consultation, one is for the medicine, and one is for the testing.
And multiple times for the test.
Correct. So
I give a sample, I go again, the result is not ready, I go still again, and they have to travel to district level for this, because labs are not there close by. Right. So each patient ends up spending about, at that time, at 2008-9, about 800-900 rupees. Now today it is 1500 rupees.
So you start with consultation, then try to solve the pharmacy issue and the testing issue.
Correct. So the end-to-end ecosystem, right? And also referral issue. There was another issue, which was referral issue. So what WHP and we did was, we tied up with certain hospitals in Delhi, tied up with a dharmashala, so that people who come from those regions can stay there for tertiary care. For secondary care, it was local specialist hospitals, clinics, and those clinics were offered training courses by WHP, which was an incentive for them, right? Apart from the patient flow that they were getting. So basically, an MBBS doctor is qualified for doing tubectomy, hysterectomy, etc. But they are not experienced in doing that, right? So WHP started those courses to train the doctors, skill development, right? So as to enable them to do these usual surgeries from which they can increase their revenues. So that became their cross incentivization for seeing the patients who come to their place for a low cost, right? So an entire, and then whole important thing that we learned out of this, and this again is one of the pillars of any programs that we build, is how to put checks and balances in the system. And this NGO, WHP, was extremely good at it, and they put up everything that we did had a check and had a balance, so that people don't misuse that. How will people misuse this facility was one of the big thought processes in the whole of the system, and how to put counter checks on it. So a lot of our product also evolved, the software product. Now, when we built the product in 2004-5, it was more like a peer-to-peer. One doctor seeing one patient with one clinic. And then when we went to a larger scale 1300 center, that was insufficient. So we actually spent a lot of time understanding the requirements of how this whole system is going to work. First thing, it worked on BSNL connectivity. BSNL landline under USOF, that is a services obligation fund, which basically is, there is a pool of funds which BSNL had, which or every connectivity provider has. When they set up in urban areas, as an obligation to the rural areas, they also have to have this donation to this fund, so that the connectivity in those areas improve. So due to that connectivity, BSNL was able to set up DSL lines in those areas, which used to give 256 1:4 kind of a bandwidth. So 256, so we used to get 1:4, meaning 64 kilobits per second, uplink and downlink, and that was sufficient for us. It was not sufficient for any other satellite, any other big telemedicine, but our system, it was sufficient. So we ran video, audio, real-time, medical records, transfer real-time data from the diagnostic devices, these lab setup, the pharmacy, supply chain, maintenance of medicines, etc. All of those things from 2008 to 2016, until which this whole program, 2014, and then it wounded up in 2016. Because of very other reasons, like the main goals of the program, like the diarrhea, leishmaniasis, etc. They were not.
So that tie-up was close.
Absolutely. So telemedicine was not the main focus of this, but it gave a beautiful technological model for the entire system, right? And it ran beautifully. There were 2 central medical facilities which were set up, one in Delhi, one in Patna. And each housing 20, 30 doctors, some specialists and most of them GPs, continuously providing care to these, and they used to call Delhi ka doctor, and then they would connect. So there was a lot of prestige in having that center there. And we had put also a framework around the RMPs, saying that you would not do these things because we are extremely afraid of quackery. And in Bihar, you can get all kinds of things. I have seen I mean, not to, it was old time. It was 2008-9 times. Now it is much improved. So I'll come to the improvements also, local.